Hello and welcome again to our weekly EKG series. I'm John Felt. I'm joined again by Dor Markush, one of our pediatric cardiologists. We're going to be talking today about the method of interpreting an EKG. So really this is the system that we should all use, just like we do in emergency medicine, of having a system for reading x-rays, ultrasounds, even examining patients. It should always be done in the same way each time, so you don't forget anything as we all get busy, and this is, I think, just as equally important with EKGs, if not more so we don't miss anything. So welcome again, Dor.
Thank you, John and Jen, again for having me. It's a pleasure to be here. So as John mentioned, I wanted to talk about a general approach to interpreting EKGs. As John mentioned, a lot of times, EKGs can look pretty straightforward when they're normal, but can look very abnormal if there's a lot of motion artifact or if they really are abnormal. And so it's helpful to just kind of take a step back and approach pretty much every EKG in the same way, and again, analyze things further or more in depth when there are abnormalities. So these are the basic steps to, again, approach every EKG. So it's very important to know the age of the patient, and that's because there are different normal values in pediatrics dependent on the age of the patient. It's a little bit easier in adults where there's just one set of normal values, but in pediatrics, a lot of things can change, including the axis of the heart, the rate, the intervals, etc. Really everything about the EKG can change, throughout childhood and into adulthood. So it's very important to know the basic, information about your patient, such as age. The EKG paper speed is important because, again, at different speeds, different EKGs will have different rates, etc. The standard.
What's the standard speed for most of our EKGs?
Yeah, the standard speed that we use is 25 millimeters a second,
okay.
And we'll see how that manifests in the EKG itself. And then calibration is another important thing because, again, even the same exact EKG with different calibration settings can look very different. And so we'll talk about that in a little bit as well. Then the other important things to look at are rate, the heart rate, the rhythm, and the axis of the EKG, the different intervals that we'll discuss, the morphology of the different waveforms, and then repolarization abnormalities as well. It's very important to know that there are different normal values based on age. And so here you see that this is the age of the patient, and there are different heart rates, there are different QRS axes, there are different PR, QRS intervals, there are different R and S wave amplitudes, which gives you also an RS ratio, and that's different in both lead V1 and lead V6 that are shown here, both the right-sided and left-sided leads. And this is important because no matter what, you should always refer to the normal values when interpreting EKGs. And so everything we talk about, it's always within the context of what is normal for a patient of that age.
So in reality, it's probably best that a provider just has a copy of this in their pocket.
Correct.
Until, maybe, after many years of using it, they have an idea of what the normals are. I mean, it's so easy to just refer to this. There's a lot of numbers to try and remember. Correct.
You don't have to memorize this. Eventually, as you mentioned, you do become familiar with the different normal values for the important things, especially at the different extremes, like the little babies and the adults and, the school-age child in between. So you become more familiar with it over time. But yes, it is important to have a copy of this either in your pocket or that's very accessible. So this is just an example of just the different what makes up the component of the EKG waveforms, and you see here there's the P wave, then you have the QRS complex, and then you have the T wave. This portion of the EKG before the QRS complex, or really up until and through the QRS complex, represents the diastolic portion of the heart. And then after the QRS complex, until the end of the T wave, represents ventricular systole. And that's important because, again, the P wave and up through the QRS complex is when the heart is being filled, or is when filling occurs, and both ventricular systole and at the end of which is the T wave starts representing, the T wave represents depolarization, and so that's just important to know in terms of what's going on in the heart. So this is the basic background of what an EKG, what the EKG waveforms are recorded on, and you see here that there's both kind of wide as well as very thin squares. And the wide squares, the difference between each wide square is 200 milliseconds, or 0.2 seconds. And if you divide that by 5, that means that each little square is really either 40 milliseconds or 0.04 seconds. And again, that's assuming that you're using 25 millimeter per second paper speed, which another way of saying that is because these are each 1 millimeter. Each small box here is 1 millimeter. And so if you take 25 of those millimeters, you get 5 of these big boxes, which gives you 1 second. So that's the 25 millimeters per second paper speed.
Okay, and we'll find the speed of the paper, or what the EKG is running at the bottom right of the EKG.
Correct. It should be printed on every EKG. The other thing is calibration, and so you'll see sometimes it's the left side, sometimes it's the right side of every EKG. You will see some marks that will indicate the calibration. So on every EKG, sometimes either on the left-hand side or on the right-hand side, you will see the calibration. And so the symbols will look something like this, or potentially something like this. And so this is what we call full standard. And this little one over here, this one is still full standard, but this little one here is half standard. And so the full standard means that it's 1 millivolt for 10 millimeters. And just like every small box is 1 millimeter going, across the EKG, they're squares. So every small box is also 1 millimeter in height. And so these two big boxes are 10 millimeters. And so 1 millivolt is 10 millimeter, and that's full standard. It's not terribly important, for the, everyday physician, because we don't interpret the EKG in millivolts, but it is important to know that when you're looking at a QRS complex and the magnitude of it, it's important to know whether the EKG is at half standard or not, because if you have a QRS complex that's only 5 millimeters in height, but the EKG is at half standard, you really have to double that, and the real magnitude of that is 10 millimeters in height. And so sometimes, for example, that patients who have severe left ventricular hypertrophy and they have really high precordial voltages, sometimes their standardization will look like this, where this is showing the limb leads are at full standard, but the precordial leads are at half standard. And that's just so that there isn't interference from one lead's QRS, going and interfering into the one above it or below it.
So they're not overlapping.
Correct. So you just have to pay attention to that, because you interpret the magnitudes differently if you are at half standard. But typically, we obtain every EKG at full standard. So the first, main thing in terms of looking at the EKG waveforms themselves is to look at the rate. There are different ways of calculating the rate. When you have an EKG, you have to look at the RR interval, and that's just the amount of time between between each QRS complex. This can vary throughout the EKG, which is why sometimes usually if you calculate somewhere in the middle, you'll get an average. But if there are a lot of variabilities, you may have to calculate this more than one interval and then average them or so. But the RR interval is, again, the time between each R wave of one beat and then of the following beat. And so one way of calculating the rate, an easy way, is to look at 300 divided by the number of big boxes. So for example, if you have between each R to R is 5 boxes, if you do 300 divided by that, that'll give you a rate of 60 beats per minute. And that makes sense because if you have 1 QRS every 5 boxes, again, that's 1 QRS every second, and that'll give you a rate of 60. Another way of calculating the rate is a more precise way, is if you do 60,000 divided by the number of milliseconds between each R to R. And sometimes that's helpful when you have a much faster heart rate, where or something where the QRSs are every 1.5 boxes, or what if they're 1.75? It's hard to estimate. So if you actually calculate the number of milliseconds between each R to R, and you do 60,000 divided by that, that'll give you the heart rate in beats per minute. Another shortcut that's demonstrated here is a simple shortcut where if the difference between your R to R is one big box, that would be a rate of 300. And if the difference is 2 boxes, that would be a rate of 150. So it's just a way of counting down based on the number of boxes between each R to R. So if you start at 1 box and progressively increase the number of boxes between them, the shortcut is 300, 150, 100, 75, 60, 50, and then 40 actually. So this is telling you, if this is 1 QRS here, okay, and then the other one is just 1 box after that, like here, then your rate is 300. If the difference is 2 boxes, then it's 150. If the difference is 3 boxes, then it's 100. The difference is 4 boxes, it's 750, etc. And this really is accurate until a heart rate of 40, which is very useful in the pediatric population. We rarely have heart rates less than that. So if you look at this first example, you see that there's approximately 1 big box between each QRS complexes, and these are the R's of each heartbeat. So this would be a rate of 300. If you go the shortcut, this would be a rate of 300. This example number 2 would roughly be a rate of 150. So you see in this third example that it's not an exact in terms of number of boxes. So if this is if it's not terribly important clinically to know the heart rate, yes, you could guesstimate and say 300, 150, 100 would be 3 boxes, 150 would be 2 boxes, and this is probably closer to 3 boxes. So the heart rate is probably around 120 or so. But if it is clinically important, then I would more precisely calculate the number of small boxes, multiply that by 40 milliseconds, and then divide 60,000 by the number of milliseconds per each between each R to R. This is just another example showing that sometimes kids could have very fast heart rates. This would be about a rate of 300 in the kid. You do see down here that this EKG is showing you the 25 millimeters per second speed, as well as the calibration that we mentioned, where it's 1 millivolt for each 10 millimeters.
Also seen on that left side.
Correct.
With the graphic there.
Correct. And so this is a wide box. If the limb leads were at full standards and the precordial leads were at half standard, you would see something that looks like this, like that, and then like that.
Got it.
And you can see that the boxes are 10 millimeters high, which is again showing you standard calibration. So the next important thing to look at is the rhythm, and really, basically, the important thing is to just be able to distinguish sinus from non-sinus rhythm. And the way we, get a sense of sinus, obviously you're not doing an electrophysiologic procedure in the cath lab, and so you just have to find, evidence from the EKG that this is coming from the location of the sinus node. You can't prove it, but you just have to look for the fact that there is evidence that this, by all means looks like a sinus rhythm. And so the way we do that is, if you remember the EKG leads, This is lead 1, and this is AVF. And you remember that the general conduction system goes from the SA node, which is up here, superior and to the right, and then it goes down to the AV node and down to both ventricles. And the general axis is from up and to the right to bottom and to the left. And so this should be the general axis of the QRS complexes that we'll discuss in a second, but also the axis of the P wave axis. So you would look at the P wave axis and make sure that the P wave axis lies here in this bottom left quadrant. So your P wave should be positive in 1 and positive in AVF. The other caveat with that is that there should be a 1-to-1 relation of the P waves to the QRS complexes. Okay. Again, there are exceptions, but as a general rule, that is the case. The PR interval is not essential because you could still have sinus rhythm with first degree heart block, etc. But those are the main things to try to make sure that you do have sinus. It's also, it is important to mention that sometimes as a normal variant in kids, you can have kind of a low, what we call a low atrial rhythm, and it's a normal variant. And so in that situation, the atrial depolarization is coming, from the low atrium and kind of going this way. And so you may still be positive in lead 1, but you may be negative in AVF, as you see, because the atrial is first being depolarized superiorly before coming down to the ventricles is normal. So that is a normal variant in kids. When looking at the QRS axis, you can see that again we've divided the heart into 4 quadrants based on lead 1 and lead AVF. And so lead 1 would be here and AVF would be here. So if you're positive in lead 1, as this first line shows, if you're positive in lead 1 and positive in lead AVF, that means your general axis is in this bottom left quadrant, which is somewhere between 0 and positive 90.
So when you're describing positivity, you're discussing the QRS complexes?
Correct. You can really analyze axis of all the different waves. You can analyze P wave axis, QRS axis, and T wave axis. And that's why for sinus rhythm it is important to analyze a P wave axis, and it's the same thing, looking at the P wave morphology in these 2 different leads. And in terms of the QRS axis, which is the general depolarization of the ventricles, yes, we look at the QRS waveform specifically.
Okay.
And this is normal. Between 0 and positive 90 is normal. Again, sometimes in little kids, because they have RV dominance, you can see a QRS axis that can approach more 120, a real newborn even higher than that, approaching 180. But these are just the different options, possibilities in terms of looking at both lead 1 and AVF. You can see that the second line, positive in 1 and negative in AVF, would be in this left upper quadrant, which is abnormal. But and so on and so forth. You can apply this to really any EKG. Then after looking at the basic characteristics and then rate, rhythm, and axis, you look at the different intervals. So the different intervals are shown here. There's the P wave interval itself. There's the PR, which is from the beginning of the P wave to the beginning of the Q in the QRS complex. So it's a misnomer. It's not to the R itself, but to the beginning of the Q. That's your PR interval. The QRS interval itself, which is the beginning of the Q to the end of the S wave. That's your QRS duration. Your QT interval is the beginning of the Q until the end of the T wave. Your ST segment is the end of the S until the beginning of the T wave. Okay, and so those are the different intervals that one can look at. The main ones that I start with when looking at an EKG is the PR interval, the QRS duration, and the QT, the corrected QTC, which we'll touch upon. And then you can also look at other things, but those are the 3 main ones to look at first. In addition to duration, it's also important to look at magnitude or amplitude. And so you can look again at the amplitude of each of these different things, and they represent different abnormalities that can be going on in the heart. But again, it's just important from the general practitioner standpoint to know that we do look at both the intervals and the amplitude. And in a different talk, we'll look at what the different abnormalities in amplitude can mean or could signify that is going on in the heart itself. After looking at the intervals, the PR, the QRS, and the QTC, we look at, the end of that is the portion of the repolarization, which is, when the ventricle is repolarizing. And the most important thing to look at from that standpoint is the QTC. The QTC stands for the corrected QT interval. The reason it's corrected is because the QT interval can vary significantly with changing in heart rate. And because in kids there's a wide range of heart rates, from much higher in the smaller kid to the much lower in the bigger kid or adult, it's important to correct for heart rate. And that's what there are different formulas used to do that. Most commonly used is the Bazette's formula, which says that the corrected QT interval is basically the measured QT divided by your R/R interval. So the measured QT is if you just take the absolute number of the QT interval from the beginning of the Q to the end of the T, that's your measured QT, and then you divide that by your R/R interval, the square root of your R/R interval. That should be done in seconds. So how I do it is I look at my QT measured, in seconds. So for example, you could have one, that's 420 milliseconds or 0.42 seconds divided by the square root, of your R/R interval. It may be, if your R/R interval is 0.9 seconds, then you would do that. And then you would get a result. You can see here that you're dividing by a number that's less than 1, so that's going to increase your QTC. It'll be higher than 420.
So you need a calculator for that.
Yes, usually.
Okay.
Unless you're very smart, like yourself. Okay, so this is just an example of a normal EKG, and you can see the different things that we spoke about. If we wanted to just, approach this using the method that we've shown, we see this is 25 millimeter paper speed. We see the calibration is normal, both based on that and based on these markings here. We don't have the age of this particular child, but it's important to look at the age again so you can interpret this. For an adult, this would be a fast heart rate. For a newborn, this would not be. So it's important to look at the age for both the rate, the intervals, and all the normal values. And then what I would do is I would calculate the rate. So again, the rate, it's about just eyeballing it. It's about, if you look here, I usually pick a QRS that's very close to a wide. That's very close to a big box. So for example, this one, and you can count here that it's just under 3 boxes. So using the 300, 150, 100, etc. rule, 3 boxes would be 100, 2 boxes would be 150. So this is about a rate of 115, 120ish beats per minute. So I look at the rate, I look at the rhythm. So in order to rhythm, again, is it sinus or not? And is there a one-to-one relationship between every P to QRS? So if you look at to determine sinus, you see in lead 1, the P wave is positive in lead 1, the P wave is positive in AVF. So the P wave is coming from that upper right quadrant, going to the left toward 1 and down toward AVF. So by all means, that is probably coming from the sinus node. By the fact that the P wave axis is normal and the fact that there's a nice one-to-one relationship with every P to QRS. So rate, rhythm, and then axis. The axis, again, we looked at the P wave axis for rhythm, and then we'll look at the QRS axis to just see the general QRS axis of the heart. So again, if you use 1 in AVF, you can see that the R wave or the QRS in general is positive in 1, and it's also positive in AVF. So it's somewhere in that, somewhere over here. Technically, a different way you could look at axis is you actually look at, you can look at your isoelectric lead, which is AVL, which, AVL here is usually this way. And then if you think about your isoelectric in AVL, so that would mean that your general depolarization is happening somewhere perpendicular to that AVL. And so that's just another way of knowing that you're probably, in the right direction. If AVL goes this way, that means, if I had a vector that was going directly this way, I would be very positive in AVL. But if I have one that's crossing it perpendicularly, that means I'm not positive and not negative. I'm pretty much isoelectric, and so that's what that's used for.
Okay.
The other thing is, if you look at lead 2, which is right where this line is marked, this is lead 2. That's a lead that's very positive, and so you're probably somewhere again around the lead AVF, the lead 2. That's your general QRS axis, and so you're definitely in that bottom left quadrant, which is normal. And then I would look at my intervals. Again, it depends on the age of the patient, etc. But I would look at my PR, I would look at my QRS duration, and I would look at my QT, and always calculate your QT as a corrected QTC. The other important thing that I'll mention is we mentioned repolarization is kind of the final thing to look at, and there are different repolarization abnormalities. But as part of the repolarization, I look at the QTC, I look at the ST segment and any changes that can come with, and then I also look at the T wave progression or the T wave axis. So the QTC we spoke about, the ST segments, obviously that should be your ST segment should be approximately at your ISO at your neutral, and the neutral is determined really by your PR segment, which is here. Anything really above 1 millimeter of a change, both up and down, can be considered abnormal. And there are also different morphologies of ST segment changes that will be discussed in a different lecture. And then the other important thing is your T waves. So general practitioners get confused about this all the time, and we get called for the fact that the T waves are flipped or T waves are negative in this lead or in that lead. In general, if you look at the limb leads, your T waves are usually positive in all your limb leads, except for in AVR. AVR, everything is usually negative because, again, AVR is over here, and if you think about it, we said the general conduction goes top right to bottom left, so you're always going away from AVR. So you're usually negative, both your P, your QRS, and your T is negative in AVR. So in general, though, in leads 1, 2, and AVF definitely, and most of the times in lead 3, your T wave should be positive in those leads. In the precordial leads, so I have a general trick of what I use to remember, and essentially you should always have positive T waves in lead V5 to V6. Those are your left-sided leads, as we've described before, and so your repolarization should always be positive in those leads. So the T wave progression happens throughout childhood. In the little babies, your T waves can be negative in the right-sided leads. V1 is the most right-sided leads, and progressively going to V6, which is the most left-sided lead. So everybody, including newborn or small babies, should have positive T waves in V5 and V6, but it is potentially normal to have negative T waves in V1 to V4. And as the child grows, as the baby or the child grows, you should progressively get your T waves should be more positive going up toward the right side. So, for example, a newborn may just have positive T waves in V5 and V6, and all the rest would be negative. As the child becomes, a couple years of age, again, sometimes less, sometimes more, V4 should flip and be positive. Then a few years later, V3 would flip and be positive. In teenage years, or before that, V2 should flip and be positive. And the adult characteristics is that all V1 through V6 all have positive T waves. Sometimes you could even guesstimate, like I could guesstimate the age of this patient just by looking at the T wave progression here and say, that this child is probably, around 5 years old or so, maybe a couple years, anywhere between 2 and 5. But this would definitely, most probably not be a teenager, for example, just looking at the T wave progression. But again, there are abnormalities that can happen at any age. So that's the general approach to EKGs. Thank you.
Well, that's great advice, great tricks. So, kind of in a quick summary, we do want to approach these EKGs in a very, in the same fashion each time. So I think, as we mentioned, looking at the setup of the EKG with speed, as well as the calibration, and then discussing, the importance of the patient's age. And then I love the rate rhythm axis, looking at the segments, and then morphology here. So thank you again. This was an excellent lecture.
You're welcome. Thank you, guys.